She is a diplomate and fellow of the Philippine Academy of Family Physicians, fellow of the Philippine Society of Hospice and Palliative Medicine, and presently the vice president of the Philippine Academy of Family Physicians, where she served previously as executive secretary as well. Currently, she's also the Philippine Society of Hospice and Palliative Medicine President, also the chair of the Manila Doctors Hospital Department of Family and Community Medicine. So she holds a lot of tasks at hand, no? Being a chairperson of the city and the provincial chapters committee, chairperson also of the basic medical education. Currently, she's also holding as a clinician and as an expert faculty. She's also a clinical associate professor at the UP Philippine General Hospital, and currently tasked as the vice chair for faculty in the same institution. So without further ado, actually pakiusap niya, baka pwedeng wag niyo nang habaan, pero we have to boast of our expert moderator tonight. So friends and colleagues, please help me in welcoming our dear Vice President, Dr. Karen Estepa Garcia, to introduce our speaker tonight.
Thank you,
Dr.
Good
Karen.
evening. And thank you, Dr. Terry Laude, for that kind introduction. And I know it's quite an exciting evening for everyone. First is we have a very interesting topic in the realms of palliative care, that is our advanced care planning. And second is that we have with us a distinguished speaker, straight from the land of the rising sun. Okay, and she is also a family medicine doctor with passion in long-term health care, in palliative care, and elderly care. So let me introduce our speaker for tonight. Dr. Machiko Inoue is a family physician, a professor of the Department of Family and Community Medicine at the Hamamatsu University School of Medicine, and the director of the Shizuoka Family Medicine Training Program in Japan. As an educator in family medicine and a researcher in primary care, and health communication, she has engaged in a number of research projects. Sorry for that. Number of research projects and published articles on quality of primary care, healthy aging, elderly care, women's health, and health services. She serves as a vice president of the Japan Primary Care Association, in charge of academic and international affairs, and as a board member of the Japan Society for Mixed Methods Research. She has served as an associate editor of the Journal of General and Family Medicine until 2020. And in 2015, she served as a member of the advisory panel of the Japan Vision Healthcare 2035 in the Ministry of Health, Labor, and Welfare in the Japanese government, which published a report on the long-term health care policy vision in Japan. Ladies and gentlemen, let me now call Professor Machiko Inoue.
Thank you very much for the thorough and kind introduction, Dr. Karen Estepa Garcia. It is my great pleasure to present today, and let me share my slides now. Okay. Can you see the slides all right?
Yes, we can.
Okay. Okay. Well, so I would like to extend my heartfelt thanks to the President, Dr. Maria Victoria Cruz of the Philippine Academy of Family Physicians, and Dr. Terry Laude, the chair of the organizing committee of the CMA seminar series, and the Johnson & Johnson Philippines for supporting the webinar. And this is my great honor, and I feel so privileged. And I would like to share my experiences in advanced care planning for end-of-life care today.
Excuse me, Dr. Machiko, I think we're having some, the one that we're displaying right now is the notes also open up with the slide presentation. So perhaps we can minimize, I think, the We can see two slides overlapping each other.
Overlapping each other? Okay. Okay, let me try again.
Thank you.
What about this?
Still there.
Still there, okay. Okay.
Okay. There, perfect.
Okay, this is better, yeah. All right, I'll start.
Thank you.
Okay, thank you. So this is Japan. And have you ever been to Japan? Well, actually, it is a very hard time for us. We cannot travel abroad anymore. And I'm so sad that this time I cannot visit Philippines. But in the future, I like to have another time to visit. So Japan has 125 million people, and the Philippines has 108 million people. And the land area is around 378 square kilometers. So the Philippines and Japan have similar population density. And I'm also director of family medicine program in Shizuoka, and I'm having the privilege of working with many residents, fellow, and faculty. So today's my topic is advanced care planning, as was introduced already. And this is a logo by the Ministry of Health, Labor, and Welfare in Japan. So the Japanese government is now promoting advanced care planning as a national policy. In general, the world is rapidly aging, and Japan is one of the countries experiencing this most rapid aging compared to other countries. So the population density is similar to Japan and the Philippines, but the proportion of the elderly in Japan is very different from the Philippines. So in 1950, the people aged 65 and over comprised only 5% in Japan. But currently, over 28% are 65 years old and older, which means today 1 in 4 persons is over 65 and 1 in 8 is now over 75 years old. And we have more than 80,000 centenarians. Can you imagine that? And it will be quite different from the situations in the Philippines. And in 2050, the number is estimated to be nearly 38% of the total population. The tandem issue is the dramatic decrease in number of younger generations who would support the society. So I think the shape of the population pyramid of your country is triangle, but Japan, it is called a pod shape. But however, the aging of society will be inevitable worldwide. So even in the Philippines, you will experience aging in the near future. And in Japan, besides the total population numbers have declined after peaking in early 2010. And although the total number of the elderly is estimated to reach at its peak in 2042, the proportion of them will continue to rise as a result of the decreasing birth rate. So you can see the blue bars, which indicates the population aged 15 to 64, and the green bars below 15 are lowering steadily. This means more people are dying than being born, which is also sad. And every year, about 1.4 million people die and 1 million babies are born, resulting in the decline of population by 400,000 every year. So this is a graph that shows the changes of place of death over the past 60 years. So 60 years ago, which is right after World War II, more than 80% people died at home. But after that, during the rapid economic growth, the universal health coverage was implemented, and many hospitals were made, and they were equipped with beds for acute care. And Japan is one of the countries with most number of hospital beds. And now about 80% of deaths take place in the hospitals, and only 20% of deaths being at home or nursing homes. So this is causing a steady increase of healthcare expenditures. And that is a big issue in the Japanese government. As shown in this figure, the gap between life expectancy and healthy life expectancy is about 9 years in men and 12 years in women. You can see that in women, the life expectancy is rising steadily, and it is now about 87 years old. But the healthy life expectancy is around 75 years old. So this means that many people spend the last years of their life requiring some nursing care, more or less. So it is inevitable that not only the healthcare costs, but the nursing costs will increase in the near future. And we will have to prevent the care burden for the younger generations financially, and the care, the amount of care in total. So for the Japanese government, it is very important to achieve a shift from the acute care to chronic care. So this is the new vision that the Japanese government is now sharing with the public. So these major paradigm shifts are considered necessary. Those are from quantity to quality, from input to values, from government regulation to autonomy, and from cure to care, lastly, and from fragmentation to integration. So these paradigm shifts are shown not only for the government, but also for the medical community directly seeing patients. For the health promotion and further development of family medicine, we will have to bear these concepts in mind for our sustainable future. So in your opinion, so what do you think would be good death? So in this COVID-19 pandemic, we are seeing so many deaths around. And what do you think is good death? So I would like to invite you to write in the chat box your opinion on a good death. How often do you see patients pass away peacefully? And how was it achieved? I would like to invite you to write down a little, think a little moment and write down something in the chat box, please. Painless, peaceful, without pain. Death with dignity. Thank you. Death with no or minimum pain, free from pain. Pain control, prepared death. Not dying alone, yes. Worry-free. No regrets. That's good. Important as well. Dignified death surrounded by loved ones. No suffering. own choice, happy, least pain, no pain. One that is accepted, free from suffering. A life well lived. Dying with confidence and everything will be all right, no worries. Surrounded by family, not alone, no regrets, own decision, fulfill the life, acceptance, just sleeping, quiet, less crying, like that. Ready to meet our Lord. Well, I love this. Contentment, acceptance, and peaceful. Thank you. Last wish is well accepted, respected, die peacefully, comfortably. Thank you very much. I really had a good views and good sense of your values and your ways of thinking as in a good depth. And I can see that you're all sharing the family medicine's values in taking care of patients. So in Japan, many people say, I would not like to live with many tubes on me, such as feeding tubes, urinary catheters, vent machine with a breathing tube, catheters for peripheral infusion or total peripheral nutrition. So such status is called spaghetti syndrome in Japan. Is it called that way in the Philippines as well? I'm not sure, I don't know, but also people say, I do not want to be bedridden for many years. You can see if you suffer a stroke in that graph I've shown before, a patient can be bedridden for years and can be in a nursing home or in the hospital for many years with these tubes on. So for many people, it is considered good death if they stay healthy and mobile as long as possible and spend just a few days on bed at the end of life. So The Economist published a report on quality of death index, ranking palliative care across the world. Among 80 countries worldwide, Japan was ranking 14. So Japan is still behind some other countries that have longer history of palliative care and hospice care. So in this report, Stephen Connor of Worldwide Hospice Palliative Care Alliance says that the biggest problem is that our healthcare systems are designed to provide acute care when what we need is chronic care. That's still the case almost everywhere in the world. So is it true? It could be also true in many countries in Asia. So now Japan has implemented this community-based integrated care system to achieve aging in place for the elderly to live and care in the community and spend their life as long as possible in the community. For that purpose, the 4 elements, which are medical care, nursing care, housing, and life support, are integrated in the local community services. And the multidisciplinary team is now employed to provide long-term care in the community under the long-term care insurance services. So not only doctors and nurses make regular visits, but also dentists, dental hygienists, and other rehab specialists, pharmacists, home helpers also make home visits as needed. And these services are all covered by the long-term care insurance. So this is the concept of aging in place. And home hospice is becoming more and more common. So this is a traditional Japanese house in a rural area in Shizuoka, where we work. So this doctor is our resident, and he's seeing a patient who was 95 years old with terminal cancer, and she had been cared at home. And you can see her son and daughter-in-law were taking care of her. So this house was her home for 60 years. So she had a special emotion for being cared at home. And right after this doctor's visit, on that day, she passed away very peacefully. So this is how we take care of the patient at home. So doctors make regular visits to the patient's home. Nurses make regular visits. And near the end, we make more often. We visit patients' home more often and provide symptom control and spiritual care as well. So let us review the characteristics of palliative care. So palliative care provides relief from pain and other distressing symptoms. And palliative care affirms life, regards dying as a normal process. It intends neither to hasten or postpone death. It integrates the psychological and spiritual aspects of patient care, and it offers a support system to help the family coping during the patient's illness and in their own bereavement. It uses a team approach to address the needs of patients and their families, and it will enhance quality of life and may also positively influence the course of illness. So palliative care is not the care provided only at the end of life. Recently, early introduction of palliative care is proved to be effective for improving patients' quality of life, symptoms, and mood without hastening death. So it is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy. And it also includes those investigations needed to better understand and manage distressing complications, such as imaging tests as CAT scan, MRI, or sometimes PET scan. As shown in this figure, in the conventional model, it was previously considered that if a patient is done with curative treatment, then the phase for palliative care started. But in the recent model, the palliative care should be introduced at the cancer diagnosis and will be provided along with the curative treatment. Also, bereavement after the patient's death for family members is considered to be part of palliative care. So this is the current model, and we will have to bear in mind that the palliative care can be started at the diagnosis. But during the course of treatment, it is also good to consider how the patients want to live the rest of their life. So it is known that in 70% cases, patients' decision-making capacity is compromised, 70%. So it could be due to sudden severe illnesses as COVID-19 or delirium, altered consciousness associated with those illnesses, cardiopulmonary arrest due to medical treatment such as intubation or sedation. So you would not know what patients really wanted at the end of life if the patients cannot express their own wills. So let's look at the case of Mrs. Murata. Mrs. Murata, 65 years old, was at the end stage of colon cancer with multiple liver metastases. She has been hospitalized for 3 months and currently undergoing second-line chemotherapy. with no tumor-reducing effect. She loves her grandchildren, Takashi and Miho, and wants to go home to spend some time with them, but thinks she should wait until she gets better to be able to go home. But her oncologist knows that her prognosis is poor and she will live only about a few weeks, but Mrs. Murdo doesn't know that. So after a few days, her consciousness declined suddenly, and she passed away at the hospital without seeing her grandchildren again, which she would have wished if only she had known her choice. If she was informed that she could go home at the end of life, well, she could have met her grandchildren. So during the course of care, patients and the family has many occasions to make decisions related to medical care and how they spend the life, and especially near the end of life. But sometimes the patient's wills and wishes are not explicit and shared with healthcare professionals or family members. So the patient's core needs are not always clear. And if you call an ambulance, you'll be brought to ER, and the ER doctors will do everything they can do to help your life, to save your life. But that could lead to intubation, sedation, or aggressive treatment, hospitalized to ICU, and then it may not be your intention. So the Japanese government has made a guideline for decision-making process for end-of-life care. So the basic principles to support patient autonomy is as follows. The patient should be provided with appropriate information and explanations by doctors and healthcare professionals. And the patient should discuss their own wills and options fully with family and involved healthcare professionals. And treatment and care decisions made based on patient's own wills. Very simple. And this figure shows that how you proceed this process. So if the patient can express their own wills, the patient themselves make decisions based on the information they've received. But if the patient cannot express their own wills, what will happen? Please look at the square in the middle. So the healthcare professionals choose most appropriate treatment option based on patient's assumed will. But the patient's assumed will may not be clear or may not be written. Then the medical care team should carefully determine what is best treatment plan for the patient. And they have to discuss very well with family members, if any. But recently, some patients live alone and don't have any family members at all with them. So it is very important for healthcare professionals to know that what would this patient like to have in the end. So before decision making, you'll have to go through very carefully with each options and discuss with family members, other healthcare professionals. And if you don't have any family members, you will consult with the ethics committee in the hospital. And the multiple experts get together and discuss and reach the consensus. So this is how we proceed the decision-making process. So what is advanced care planning? So it is defined as follows. Some of you may know already. The advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And the goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. So ACP is a voluntary process and should not be pressured by family members or healthcare professionals. And with the individual's agreement, discussions are documented and regularly reviewed, communicated to key persons involved in the care. And if the individual wishes, their family and friends may be included. And it is very important to set a very good time and in a private and comfortable setting. So ACP is a process, and it can include writing advance directives or making DNAR orders by the physicians. But it is not the goal, or it is not mandatory. ACP is a series of discussion that takes place many times over the course of care. And it is important to understand the patient's values, not just the particular preferences for treatment, such as chemotherapy, medical ventilation, enteral feeding, urinary catheter, etc. Because those options and merits and demerits for them will change over time or depending on the situations. So in Japan, advanced care planning is not legalized, and advanced directives do not have any legal impact on the care. But although the patient's written will are respected and the decisions are made based on that guideline, and we respect if the patients have any written wills or written preferences. So an ACP discussion might include the individual's concerns, their important values, personal goals, and their understanding about their illness and prognosis, as well as particular preferences for types of care or treatment that may be beneficial in the future and availability of these. So there's a classic typology of illness trajectory. So according to Lynn's paper in 2001, most of the illness courses follow one of the three patterns she proposed. And the care should be matched according to the prospect. First, in case of cancer, which is about 20% of cases, the patient looks stable for a certain period after the diagnosis and during the treatment. But at some point, there's a short period of obvious decline of functions near the end. It's sometimes difficult to predict the prognosis, and the patient and the family do not share the same understanding of it. So that could be the issue. So for a patient with cancer, the patient must be prompted and supported as they receive disease-directed therapies, such as chemotherapy as well as surgery, to express their care goals and make decisions for their future care that are congruent with their wishes. And the right of patients or their caregivers to decline life-sustaining treatment or interventions need to be protected. And ACP discussions may evolve over time and represent a balance between patient autonomy and the input and guidance from caregivers. And oncology providers should ask for preferences on how patients wish to receive information about end-of-life options and prognosis. So secondly, the patients with chronic organ system failure, such as heart failure, chronic kidney disease, respiratory failure, and cirrhosis, experience periodic exacerbations, and admission to the hospital may be needed in such occasions. They recover each time, but their functions do not usually recover fully as before the admission. And after gradual decline of functions, they experience the sudden exacerbation, and that might lead to death. And the timing in which is mostly unpredictable. So such cases comprise about 20%. So for these patients, so advanced care planning should be done at the admission, at the discharge, and home visits. So many times you can do the ACP discussion and preparing for the sudden exacerbation will be important. Lastly, the third pattern is seen in patients with frailty and dementia. So you can see patients' functions decline over years, many years, slowly and insidiously. So even patients themselves or family members are not aware of the clear decline of the functions. And decreased oral intake could lead to a decline of oral function and lead to occasional aspiration pneumonia. And falls and fractures are commonly seen. So they will follow slowly dwindling course to death and near the end of life. Many patients could be bedridden in the end and depend on some support for nutrition. So for patients with dementia, their mental capacity gradually declines and verbal communication becomes more difficult or even impossible. So involvement of those close to the person from the initial stages of condition and is of the utmost importance. And mental capacity should be considered as a continuum that fluctuates over time and is task specific. So if a patient cannot decide on what to eat today, the patient can express something that they want to do today. So could be task specific. So what is known about advanced care planning? So let us review some of the history of ACP. So it was in 1990s when inadequate end-of-life care started to draw attention. So healthcare professionals had poor knowledge of patients' wishes about the medical treatment. At the time, they lose the capacity to make decisions. And during the 1990s and around 2000, in the countries like US, UK, Australia, to name a few, made legislation for patient autonomy to provide patients with greater say in the end-of-life decisions. And Taiwan was the first country in Asia that made Patient Autonomy Act. And the support study is the first intervention study to improve end-of-life discussion. And this first phase project was an observational study, and the second phase was interventions. But the intervention didn't show any significant improvement in the outcomes. Next, the Respecting Choices program in Australia showed an effect on the improvement of the patient outcomes. And it deployed a different approach compared to support study. So it used a coordinated approach to ACP And the trained non-medical staff helped the patients to discuss their end-of-life wishes. So it reduced the incidence of anxiety, depression, and post-traumatic stress in surviving relatives. And it improved patient and family satisfaction with hospital care. So after that, overall, to elicit the patient's ideas and thoughts on how they want to live and make them articulate, the communication skills are important. And the multiple communication skills training, CST, has been developed, and their effectiveness has been researched. So one of the successful programs is the Serious Illness Care Program, based on the Harvard University studies. And it provides serious illness care guide as a communication guide. And the training courses uses this guide. So I'm sure that in the Philippines as well, you can access this program, and some of you might have experienced the training sessions. So in this guide, the conversation begins as follows. First, you set up the conversation. Second, you assess understanding and preferences of the patient. 3, you share the prognosis. And you can use I wish statement, like I wish we were not in this situation, but I'm worried that time may be as short as a few months for you. And 4, you will explore the key topics, its goals, fears, worries, and sources of strengths in the family. So you can say that, what are your most important goals if your health situation worsens? Well, what gives you strength as you think about the future with your illness? If you become sicker, how much are you willing to go through for the possibility of gaining more time? Or how much does your family know about your illness or your wishes? And you close the conversation and you document the conversation. And you will lastly communicate with the key clinicians about the discussion. So using this model, a cluster randomized trial was conducted to assess the effectiveness of this intervention program. And the 278 patients included in the study. So it showed that the patient's anxiety and depression have declined after the intervention, as you can see in the figures. Another communication skills training programs is the Vital Talk. And this is translated into multiple languages. And in Japan, it became available in 2019, very recent program. And there's also a 4 days train the trainer program as well. And so I assume in the Philippines, the program was introduced, and you can log into the Vital Talk site. You can get more resources about the serious illness care conversations. So in this Vital Talk, there are some tips for responding to emotion at end of life. So you can use phrases like, tell me more about. So you don't jump into an assumption and just explore what the patient thinks. And you can also use ask, tell, ask as a unit of information transfer. So don't talk. And we usually don't have enough time to sit in with the patient and listen to them. So, but we have to change our mindset and sit in and ask, tell and ask. And again, you can use I wish statement. Like, I wish I could say that the chemo always works. And by using this I wish statement, you can align with patient while acknowledging that the reality is different. So you can see the videos on this website, and so please refer to them later. And the spikes model, this is very popular and well known in the palliative care settings. So I think you're already familiar with this, and I will not go into the details, but this is always helpful for us. So there is a systematic review paper on the barriers and enablers of ACP discussion in general practice. And it shows that there are 4 levels: individual level, interpersonal level, and provider level, and system level. So these barriers are very common in our settings. And not only the provider levels, but we do have barriers in the interpersonal level, and we are ambiguous about talking about ACP. And we, at the system level, if we lack the IT system or templates to share the information with other healthcare professionals, that could become a barriers too. And these are key enablers of the ACP discussion at the general practice. So the education and public awareness will be enablers. And at the interpersonal level, the group interaction among patients will help. And at the provider level, we need a team approach and the communication training, as I have talked about previously. And at the system level, the IT systems like portals, prompts, decision aids, templates would help. So these are the do's. So it is always good to pick up the cues of the patients. So sometimes patients want to talk about their worries, but the healthcare provider says, oh no, don't talk about it. It will be okay. Or just you want to close the conversation and stop exploring the patient's ideas or worries. So it is very common among nurses, physicians, and home helpers, care providers. So just stop and listen to the cues of the patients. And record and sharing the information is also important. And these are the don'ts. So don't force the patient to talk or think about end of life if they're not willing. So if you force them to talk, it could be harmful. And the Japanese patients are not usually comfortable talking about death. And don't share the information if the patient doesn't want you to do that. So ACP can be done as a part of routine care. And here's the video by the Advanced Care Planning Australia made in 2018. And I would like to just show a very quick video.
There we go, you can have your finger back now.
Thanks.
Michael, it's really good that all your tests are stable, your CAT score's stable, or your blood tests are stable. It's really good to see that you're looking after yourself. Michael is visiting the practice today to review his chronic disease management plan. After my initial assessment, I checked with him to see if there were any other concerns. At these appointments, aside from checking out what's happening with your body, we also like to give you the opportunity to tell us what's concerning you so we can help with that. So is there anything concerning you?
I must have been a little worried about what happens if something at home happens. What does she do? Ring an ambulance? I don't know if I really want that. I would like to stay away from hospitals as long as I can. But then, if I get seriously ill, is it going to be too much for her?
I can understand why you'd be concerned about that. Some things we can do. We can put you in touch with some community services, some palliative care or some home nursing services that might be able to help you at home.
No, I don't think we need that yet.
No. I can understand that. But what about if you did fall? What would happen?
I don't know.
Something you could be thinking about now would be someone who could speak on your behalf if you couldn't speak for yourself.
Well, wouldn't they just ask me?
Yeah, they probably would. But you need to know what's important to Michael, what sorts of decisions you'd be making on his behalf.
We've talked about that.
That's really fantastic. So Sherry would know what you'd want if you did collapse and if you did need to go to hospital?
Well, we haven't really talked in that detail yet because, we don't know what's going to happen.
Yeah, it's hard to know what's happening in the future. None of us have got a crystal ball. Mine's broken. It is important to have a chat about that. It's important for us to know what you would want so we could act on your behalf.
Right.
So you've already obviously started the process. You're thinking about it. And that's the first step. The next step is to talk with someone about it. You've started talking with Cherry. Yeah. That's really great. The next part of the process would be to formally appoint that decision maker, someone who could speak on your behalf if you couldn't speak for yourself, someone who's confident, who knows what you would want. Mm-hmm. Yeah. The next part of the process is to write it down, writing down what your wishes would be if you couldn't speak for yourself, so we can all work off that same page, and then sharing it with the healthcare team, so with the hospital.
Thank you. So as like this, you can bring the topic in the routine visit and ask the details about their wishes and explain how to write them down and how to appoint a surrogate decision maker. So how would you do this in the community? So in the clinical setting, you do it in that way. And you can also implement the ACP program in the community. So I would like to explain a little about the community settings. So in this time with COVID-19, as I have talked in the beginning, you will not know when you will become ill and lose your decision-making capacity. So we encourage healthy elderly people to think about their preferences, values, and desires in advance. So in the Japanese culture, sometimes it's difficult to talk about death and dying. So we encourage people to use some tools to promote this discussion. First, so this is a card game. A group of Japanese doctors developed a set of playing cards for people to have fun as they think about their values about the end of life. So on each card, there's an item to consider upon. And when you pick a card, you can consider how important it is for you. So there are 35 cards, and you play with other family members, friends, and at the workshops like this. So these cards can be used in various ways. And you will know that what is really important for you. But the idea could change over time, And so in this group setting, you will know the diversity of the values. So another popular effort is to write a note. So this is a conversation project by the Institute of Healthcare Improvement in the US. So, and it shows that how to start the ACP conversation with family members step by step. So this guide is translated into many languages and used widely in the world. The step 1 is to think about what matters to you. Step 2, plan your talk. Step 3, start talking. And step 4, keep talking. And this is an ACP note we have developed in the Hamamatsu city. So in Japan, all the municipalities are now promoting ACP as their own way, and they're making their own note and providing the note to the elderly. So we have already distributed 5,000 notebooks to the elderly in the city. And we are doing it more, and the people can download the files as well. So the point is that it is not an advanced directive. This is not to be used in the medical settings, but this is for the general public to consider the advanced care planning. So in this note, so it is asked what kind of care you would prefer to have at the end of life, and the Lean's typology of illness trajectory is introduced in a simple way. So on this page, you are prompted to reflect on your life and think about what you would like to do from now. What is your meaning in life? What would you find interesting? What would you want to do until the end of life? And what are your concerns? And the COVID-19 pandemic makes people to think more and more about death and dying and sudden illnesses. And this lady is 83-year-old and joining the workshops about ACP, accompanied by the 55-year-old daughter. And the lecturer guides what to think about and how to use this note. And she also writes about her funeral. So in the community setting, the multiple workshops and seminars are now conducted in this way, even in the pandemic. So let's now move on to the challenges and ethical issues of advanced care planning. So there are also challenges. So what if patients' wishes and family's wishes are not congruent? How would you respond? Is it observed in the Philippines as well? In Japan, there's often a conflict among patients, family, and healthcare professionals on whether or not or how much parenteral hydration should be administered near the end of life. And the patients don't want painful procedures anymore. But family members want the patient to live longer, as long as possible, and don't want to give up the infusion or any intervention. And sometimes we use subcutaneous infusion, but still the venous infusion is more common. And physicians tend to believe hydration is important and good for patients, but evidence, as shown on this graph, shows that it does not actually prolong life of the patient or improves the quality of life. So sometimes we negotiate with the patient and the family, and the doctor in the home service care will provide minimum hydration, like 500 milliliter per day, by a subcutaneous way or parenteral hydration. Another common problem is the daughter from California syndrome. It's commonly observed when a daughter or a son who had not seen the patient for a long time or only occasionally appears at the very scene of the critical decision making in the end. And they usually become very surprised to see the patient on the verge of death. And they express denial, anger, and resentment toward healthcare professionals. And it is very difficult sometimes to resolve the conflict in family and between healthcare professionals and the family members. To resolve this issue, you will need to talk through the patient from family, and it will not be easy. So to avoid such situation, the idea of ACP is also important. So if ACP is widely spread, then such issue will not be a problem in the less way. Is there a name for this syndrome? Good. Okay. And so there sure is a cultural difference in a decision-making style. In Asian countries, the idea of relational autonomy is now discussed. So we tend to make decisions based on the relationship with families, friends, and healthcare professionals. So it's a little different from the Western way of decision-making, individualism. So we're living in relationships and we make decisions according to the relations. And the Taipei Declaration was published in 2019, and this Asian consortium will discuss this topic. And it has just started, so please look forward to what will evolve from this declaration. So far, I have talked about ACP at the end of life, and especially at the general practice in the community settings as public education. So here's my last slide and my message for you. First, the preferences and decisions may change over time and depending on actual situations. But the values, core values, will not change that often. So just listen very carefully to the patient's core values and be with them and respect the patient's core needs. And lastly, don't forget to share your hope to the patients. Don't abandon patients with despair. Just sharing the hope is what we can do as family physicians. So I really hope my talk will help you to face with the elderly patients or patients with cancer and who will potentially need ACP. Thank you so much.